Good afternoon, everyone. Thank you for attending CORE. We're going to be talking about clinical cases today and two chronic illnesses that you will see during your PPC training time, including asthma and cystic fibrosis. So we're going to go through some simple slides. At the end, there'll be a few case presentations that I will review, but we will talk to them as a group after you watch this recorded presentation. So asthma. The goals for our talk today is to describe the basic pathophysiology. We're going to review the incidence and complications, triggers. We're going to talk about asthma therapies, and we're also going to review why adherence is so important. So what is asthma? Asthma is a disease process that's characterized by chronic inflammation. It's associated with airway hyperresponsiveness, and this can lead to episodes of wheezing, shortness of breath, chest tightness, and cough. It's a widespread disease, and it's variable with recurring and often reversible airflow limitations. If you see in the diagram, on the left is a normal airway, and on the right is the airway of an asthmatic. And as you can see on the right, children with asthma can have air trapping in their alveoli. They can have tight and smooth muscles, and this can lead to increased mucus production. And as you can see, it makes it very difficult for them to breathe. As far as the incidence of asthma, approximately 1 in 12 or 6 million children have it, and can lead to upwards of 14 million missed school days, according to the National Health Interview Survey back in 2013. We can see that children that are hospitalized for asthma is actually improving, as well as school missed days. Those are actually increasing, and we're going to talk a little bit about why that happens. One of the things that can complicate asthma is living in the city. We know that oftentimes city air quality is poor. There can be such things as indoor allergens like dust mites and cockroach that is higher in inner city youth. Lack of education can be a tremendous barrier, as well as poor access to health care. Oftentimes, people that don't have access to health care on a consistent basis tend to visit the emergency room and can lead to higher rates of both emergency room visits and hospitalization. Back in 2011, the National Center for Health Statistics estimated that approximately 19% of all U.S. children had at least one ER visit, and this can equivocate to 25 million ER visits by children annually. So one of the things that we talk about with asthma when a child comes to clinic with their parents is the risk factors, as well as the triggers that can make asthma worse. We know that genetics can actually explain why some children with asthma are worse than others. So oftentimes for that first visit, we will ask the parents if there's anyone else in the family that has asthma. Allergies can be another issue that can affect asthma. Those can include eczema, which some of you may know. It's dry, patchy areas, and so sometimes if a child has eczema that's not well controlled, we want to assess that to see if they need additional treatments. As well as allergic rhinitis, often manifest as itchy, watery eyes, runny nose, sneezing, and food allergens. If there is a concern for high food allergens, then we would want to refer them to an allergist. We also want to consider in Florida that the seasonal allergies can certainly interplay with a child with asthma. We know that tree pollen can occur as late as December and actually continue through May. In the fall, we worry about molds, and oftentimes, depending upon school areas where a child is living, you would want to assess whether or not there's mold exposures. In the spring, everything is blooming, and so a lot of folks have problems with symptoms then. So we want to make sure if they're having any of those that we're treating those symptoms correctly. The other big factor for people living in Florida is ragweed. The picture up on the right is actually a dust mite allergen, and so if we have a child that has a lot of itchy, watery eyes early in the morning, we think dust mite allergy, and so we consider actually doing some additional skin testing to see if a child does have allergies to those things that I mentioned. One of the other factors and triggers that can certainly affect children with asthma is severe lower respiratory tract infection. Some of the things that you may have heard about is pneumonia and bronchiolitis, where you get wheezing, and oftentimes you can get a productive cough depending upon the situation. One of the first things we talk about for a newly diagnosed asthma is we'll ask the parent, do you notice that your child wheezes when they're not sick? And if we get that history, then we often think that asthma may be an interplay here. We know that gender is a factor. In males, childhood time period with wheeze is higher, and that actually switches in adolescence with a higher incidence in females. And then oftentimes in adolescents and adults, females can actually have worse asthma. We know that low birth weight is also a risk factor because low birth rate sometimes ties with lung health, and so we also want to question a parent about prematurity. And then lastly, a smoke exposure. So what are the goals of asthma? What we want to do is control the asthma symptoms, and it tends to fall into two risk categories. We want to reduce the impairment and we want to reduce the overall risk. Well, how do we do that? Well, we want to prevent those chronic and troublesome symptoms of cough, shortness of breath in daytime. We often ask parents how often we are having those symptoms, and one of the goals is to make sure that the child does not need rescue therapy more than 2 days a week, because if that's the case, then the question is whether or not their symptoms are well controlled. And typically anything more than twice a week, we consider that uncontrolled asthma. We want to maintain near or normal pulmonary function test, also known as a breathing test, so you should get exposure to that during your rotation. We generally start breathing tests around the age of 5. It's not the easiest thing to do. So we are very happy with our respiratory therapists that are able to get these testing done. We want to make sure that there is normal activity levels. Just because a child has asthma does not mean that they can't participate in exercise, and that's one of the things that we ask about, because oftentimes we will have a parent that will report that they are limiting their child's activity because they're concerned about an asthma attack, and so that's actually a point that we need to address with a parent and an opportunity for education. We also want to meet the patients' and families' expectations and their satisfaction with asthma care. Just because a provider feels like a patient needs to have medications on a daily basis doesn't necessarily mean that a parent may believe that. And so we definitely need to look into their cultural beliefs as well when we are doing that history and following up on that education. To reduce the risk, we want to make sure that we're preventing recurrent exacerbations of asthma, because with recurrent exacerbations of asthma, there is a higher incidence of oral steroid use, which we want to minimize, as well as ER or hospitalization overutilization, and we want to make sure that we're not doing that either. And why is that important? Because we want to prevent loss of lung function for children and prevent reduced lung growth. And we also want to provide a personalized optimal pharmacotherapy with minimal to no adverse events. So in other words, I talked about frequent oral steroids. We want to make sure that we're not prescribing as much of that, because again, it's a sign of poor asthma control and there are more side effects associated with that. So the National Health Lung Blood Institute has developed guidelines back in 2007. They've been updated since then. And recently the GINA guidelines have been developed to help providers that are assessing a patient that comes to clinic that may not be a pulmonologist, how to determine whether or not that patient has asthma that is well controlled or not well controlled. And so you can see from this snapshot that it's broken out by age group as well as frequency of symptoms. And so, for example, if we have a parent of a 6-year-old that comes in and says that they have been utilizing the albuterol since they were first diagnosed a month ago, they've been using it 4 to 5 times a week, we can see that that is not well controlled. And so if you drop down to the bottom in the blue section, it talks about stepping up the therapy. But most important, before we do any treatment, is making sure that we're getting a good history for what's going on, because this is an opportunity to find out if the education that we taught a month ago for that new diagnosis was actually heard. It might be that the parent misunderstood the difference between taking a medication every day versus taking medication only when needed. That often happens, and so if that's the case, then it's opportunity for re-education before we actually step up the therapy. So speaking of therapy, what is the therapies? Typically, asthma medications are listed under 3 different categories. The preventative medication, also known as maintenance medication, that's given on a daily basis. The purpose of the preventative medications is to treat the underlying irritation or inflammation going on in the lungs, which, as you can see on the pictorial on the right, is really a good descriptor for parents. Rescue medications, on the other hand, their focus is to actually treat the symptoms. So oftentimes, if I have a parent that comes in and is explaining that they are using albuterol a lot, I may explain to them and talk to them and use this diagram to explain that the albuterol is only used for rescue. It's not going to treat that underlying irritation and inflammation in the lung, and the most important medication for that is the preventative therapy. So it decreases the airway sensitivity to the triggers, as well as symptoms and activity impairment. It can improve exercise tolerance as well as quality of life, and decrease that need for rescue therapy. Typically, it's prescribed either on a once or twice a day basis. I mentioned the rescue therapy, also known as albuterol. ProAir is another name for that. And then the third category is step-up therapy, which is biologics, which tend to be prescribed after skin testing to identify whether or not there's any significant allergies. If there are, and it's decided that a child needs biologics, those are administered subcutaneously under the skin. An example of that would be Xolair. So I mentioned at the beginning of the presentation that we were going to talk about adherence, and why is that important? Well, as I mentioned earlier, if there's overutilization of the albuterol and not enough use of daily therapy, then we're not really treating the underlying cause, which is that irritation and inflammation. As you can see from this diagram from the National Health Interview Survey back in 2013, 25% of people mentioned that they are not utilizing their medications regularly as prescribed, but look at the use of the rescue medication. And one of the things that's most difficult about that is, let's say I've been diagnosed and I've been told to take a daily therapy, and I can take that as prescribed, but I don't really notice a difference one way or the other. Is it helping? Is it not helping? However, if, let's say, for example, I'm hiking with friends, I acutely get short of breath or I cough, and I take my rescue medication, I notice that my cough and my shortness of breath can go away. And so I think, well, that's the medication that's really working for me. Unfortunately, as I mentioned, it's only treating the symptoms. It's not treating the underlying cause. And so when you see that high incidence of rescue medication use, that 68%, what you would also see is there's overutilization of emergency room and hospitalizations, as well as secondary complications that may occur with an acute asthma attack. So I talked about preventative versus rescue a couple slides ago, and there was a lot of explanation. So if you have a new patient that's coming in for the first time that have never seen these medications, it may be a little bit overwhelming for a parent, particularly a parent that has many children, to be given a couple of inhalers and told, take this one every day, take this one only when you need it, and oh, by the way, if you have allergies, make sure the child doesn't have it. That's a lot of information to give someone at one time. So if that child is educated as well as the parent and asked to come back in a month just to kind of reaffirm to make sure things are going right, and the parents gets things confused, then one of the things that we often utilize to help describe the difference between the two is on the right. You see that's rescue. We say red for rescue. An example on a medication on the left is Flovent, and we often say Flovent is your orange inhaler. That is the one that you need to take twice a day, every day, as prescribed, but the red is only if you need it for rescue. So every opportunity we should take, educate, educate, educate. So one of the reasons that we have children use chambers when they're giving their medications is because developmentally they have a hard time at utilizing those metered dose inhalers, and that metered dose inhaler is the little white thing that's sticking at the end of the chamber. You might have a parent that come in and says, hey, I have a 3-year-old, but they're really smart, they don't need the chamber. Well, actually they do, because if they don't coordinate it correctly, then really what's happening is they're just coating the back of their throat instead of down into the lungs.
Writing's not that easy, but Grammarly can help. This sentence is grammatically correct.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Jerk.
So for those of you that may remember House, he was not very well known for his bedside manner, but one of the most important things he did ask was about that inhaler technique. Oftentimes in a busy primary care office, if a parent comes in and says this medication is not working, sometimes the first knee-jerk reaction is to switch it to another medication, thinking that that might work better. However, if it's all technique, then that's really what we need to work on. And so instructions that we give is to shake the inhaler. Again, that's that white thing you see on the left side. And then we want to fit it into the inhaler. 1 squirt, and then we ask the child to take 5 or 6 breaths in. If you look right in front of her eyes, there's actually a little valve there that moves back and forth that will give confirmation to a parent that that breath is actually being pulled in enough to pull that medicine down into the lungs. We ask the child to do that 5 or 6 times, take the mask off, and then we repeat that for that second puff if that was prescribed. It's very important that the seal is adequate, because if not, then the child is losing medication. One of the things that's very important is written instructions, because as I said, if you've got a parent of 5 children and some of them are in the clinic, how much are they really hearing you with a child that is demanding their attention? So we ask for written instructions of what medication we would like the child to take on a daily basis, what we would like to take for rescue therapy, and actually really write down what is rescue therapy, when do I need to give it, and if it's not working, what is the next steps? Do I need to go to the emergency room? Do I need to call my doctor? And so that should be clearly written out and also reviewed with the parent before they leave to make sure that they are understanding the written word. So we talked about needing rescue therapy. It's also very important that parents understand what constitutes an emergency, what constitutes calling the doctor the next day versus either going to the emergency room or calling the on-call provider. Some of those are listed, which is talking in broken sentences because the child is so short of breath that they cannot do anything but that. Changes in mental status. Accessory muscle use is things such as nasal flaring, pulling in of the rib cage, pulling the shoulders up to try to get some breathing in, and then those other symptoms are pale or blue color around the lips or fingernails, difficulty breathing, and then when the airways get very tight, and this is really important for school nurses, wheezing often goes away, and the reason for that is because the person cannot breathe enough force to cause the wheezing, and so that's important for a parent to understand as well. So in conclusion, you want to make sure that you are assessing asthma control at every visit. We also want to make sure that the educational status at every visit is checked. We want to assess for poor perception of symptoms. Oftentimes we'll have teenagers that will come in and say, I'm not having any cough, wheeze, shortness of breath, and then we'll have them do breathing tests and discover that they have moderate to severe airway obstruction. And so that is an opportunity to really talk to both the parent and the child because there may be a poor perception of symptoms. They may have been living with this for years and just not understanding what it is to take a really good deep breath. We also want to assess the ability to pay issue. A lot of times with Medicare patients, their medications are covered. We tend to not look at the insurance status. And sometimes we have patients that have good insurance, but they have really high copays. And so having to come up with $200 or $300 a month to pay for these medications may be very difficult. And parents a lot of times are embarrassed and don't want to admit this. So we don't find out until months later when they come back for a repeat visit. We can't figure out why they're having airway obstruction and all these symptoms if they're supposed to be taking their medication. And then we find out they haven't filled in a couple of months. So it's important to consider that. It's also important to assess the parent oversight. Many of our parents both are working outside of the home, and so a grandmother is left to take care of a child who may or may not be able to give good oversight. If they can't see when a child is taking their medication or maybe they are not as well coordinated. So it's important to ask at those visits who is responsible for giving the child their medications. And it's also important to assess the parent oversight with kids because oftentimes a parent will feel like an 11-year-old should be responsible for taking their medication every day and is not watching them do that. And then the child comes to clinic, the lung function is poor. Come to find out, the child admits to forgetting the morning doses because they're busy getting ready for school. So it's really important to talk about that during those educational sessions. We also want to assess the child's cognitive ability to understand their own care as well. Again, a lot of parents may feel like the child is old enough, but cognitively they may not be old enough to be able to understand the importance of taking that daily medication. And then the other thing that is important is to tailor those asthma treatments using the guidelines and best practices. Again, the NHLBI guidelines that I mentioned earlier are guidelines. You have to consider the patient that's in front of you. If you have somebody that's never taken their daily therapy because they can't remember to take it twice a day, then you have to consider, well, maybe I can switch it to once a day with a certain medication in order to increase the adherence. Here's a quick case presentation. I'm not going to read through. You can see it now. And what we're going to do at the end of the sessions is we're going to run through this case presentation and get some dialogue. The other thing I want you to do is to consider follow-up observations. What, if any, preconceived notions about asthma have changed for you? What is the take-home message for your future interactions with children with asthma? And how can partnerships enhance the care that you give to children with asthma and their families? So we're going to switch gears and we're going to start talking about cystic fibrosis. As I mentioned, this is another disease process that you will see in the clinic during your rotation here with PPC. The objectives is to define what cystic fibrosis is. We want to know how it is diagnosed. What are the manifestations of? We want to know treatment, and we also are going to touch a little bit on research. So what is cystic fibrosis? CF is a rare genetic disease. It's found in about 1 out of 30,000 people in the United States. It's an inherited disorder. It causes severe damage to the lung, and there can be episodes throughout the lifetime of infection, inflammation, respiratory failure, malnutrition, poor growth, and liver disease. As early as the 1800s, we feel that CF was first charted. Actually, the musician Chopin was thought to have a mild case of cystic fibrosis. But some of the earliest medical literature was back in the 1930s. There was a pathologist by the name of Anderson who was doing autopsies of children with CF of the pancreas. And noticed that there was a lot of what they at the time was known as mucoviscoidosis. So there was a lot of thickening, a lot of mucoid tissue. So she first described that. But it wasn't until the heat wave in New York City in the early 40s that a physician by the name of Paul Saint-Genès noticed that children with cystic fibrosis actually had higher salt content. And the gentleman that you see up there on the left is Dr. Francis Collins. He's currently the director of the National Institute of Health. He was actually instrumental in discovering the CF gene many years ago. The infant on the right is undergoing what we call sweat testing, and it is considered the gold standard for the diagnosis of cystic fibrosis. What you see on the child's upper limb is basically a system of stimulating the skin so that we can collect the sweat. Once we collect the sweat, it's sent off to the lab. Typically, the results are given the same day. And oftentimes it's a very disconcerting call for a parent to get to say that your child has CF. The first thing they do is they go on Google and find out that they find about the mortality incidence. And so it can be very upsetting time for parents. So how does a person get CF? In order to have CF, you must have 2 copies of what we call the cystic fibrosis transmembrane regulator gene that contains mutations. You get 1 copy from each parent, and that means that each parent must either have CF or be a carrier of a CFTR mutation. On the left, if 2 people are carriers and have a child, there's about a 25% chance of a child having CF. But when the percentages go up and 1 parent has CF and 1 parent is a carrier, there is a 50% chance of a child having CF. When children are born, they undergo newborn screening. That is the initial flag that may come back to a cystic fibrosis center somewhere in the state. When those results come through, it's that center's responsibility to contact the primary care provider as well as the parent to give them the news that there is a chance that their child may have CF. And in that case, the center will arrange for that sweat testing, as I mentioned, which is the gold standard in the coming weeks. So what is CFTR? CFTR is a protein. There are 3 problems that can occur with someone that has CF. Either the protein doesn't work well, there's an insufficient quantity, or it's not produced at all. And there's a short video I'm going to have you take a look at.
Cystic fibrosis, or CF, is a genetic disease that affects multiple organs, including your lungs, and limits your ability to breathe over time. Your main airway, called the trachea, branches into each of your lungs. The largest airway within each lung is called a bronchus, and each bronchus branches into smaller airways called bronchioles. Normally, airways are coated inside with a thin layer of fluid and mucus. The mucus catches dust and germs from the air you breathe in. Then, hair-like projections on the airway surface, called cilia, push the mucus, trap dust, and germs out of the lungs. In cystic fibrosis, the mucus is so thick and sticky that the cilia can't push it out of your lungs. This thick, sticky mucus can build up, trap germs like bacteria, and block your airways. Because of this, you may periodically have acute infections or exacerbations of the disease, causing symptoms such as increased coughing, production of mucus, and shortness of breath. As the disease progresses, long-term damage can occur in your lungs. This happens when germs, like bacteria, get into your lungs and cause chronic infections and inflammation. But there's a lot you can do to control the infections and slow the progression of lung damage. Talk to your CF Care team about how the different parts of your treatment plan can help keep you healthier. As your partner, they can help you find ways to fit your treatments.
Continue going, a few seconds more in.
So what are the complications that can be occurring with someone with cystic fibrosis? Oftentimes when you go to the clinic, you'll see that they have productive sputum. There can be cross-infection with other respiratory issues. They are often seen by a nutritionist because of the nutritional deficiencies that can lead to weight loss. They can also develop something called cystic fibrosis-related diabetes. They can have liver disease. They can have intestinal obstruction, also known as DIOS, and there can also be fertility issues. If you look on the right, there is a picture of a CT scan of a normal person, and on the right is an individual with cystic fibrosis, where you get multiple sections of mucus plugging, which can lead to scarring. I mentioned that you can have growth failure with cystic fibrosis. Oftentimes this is because of poor digestion. The child that has CF can oftentimes have trouble absorbing the nutrients, and so in order to help with that, they are often prescribed pancreatic enzymes. It have to be taken in timing with their food, and so as you can imagine, sometimes that can be a difficult thing with a parent that's trying to run down a busy toddler to make sure that they swallow oftentimes many pills, but if they don't do that, then there is a good chance that they will malabsorb or not get the best nutritional outcome from the food that they eat. It's very difficult to clear those secretions, and oftentimes it requires more energy to breathe. They have to repeatedly fight off lung infections. It takes much longer to get over these lung infections than a normal cold for other children. And so as a result of this, children with CF need more calories, and sometimes that can be 1.5 to 2 times what a normal individual would require. Their diet is usually high in fat. They need to be assessed frequently for their nutrition, and so as I said, when they come to clinic, they see a whole host of individuals, both a nutritionist, they will see social workers, a nurse, a provider, respiratory therapist, and if the center is fortunate enough, services of psychologist. We'll talk a little bit about modulators down the road, as well as the role of vitamins. And our own Ellen Bowser actually participated in the Academy of Nutrition Dietetic review of analysis of literature that had been done for nutrition and CF, and those were posted in 2020. So I talked earlier about asthma therapy and a couple of medications, daily therapy versus a rescue therapy. Unfortunately, if someone is diagnosed with cystic fibrosis, those treatment options can be very overwhelming. The treatments take long periods of time throughout the day, and we're going to review a few of those. So when a child has an increase in sputum production and problems with maintaining weight, oftentimes we think they're having a flare-up of their asthma, not of their asthma, a flare-up of their cystic fibrosis, and often need to go on antibiotics, and this can be anywhere from 10 days to 3 weeks. Airway clearance is a mainstay with children with cystic fibrosis. There are many avenues to utilize this, including vest therapy, cough assist devices, there's PEP devices, there's chest physiotherapy, but whichever modality is used, we typically request that a child does airway clearance at least twice to 3 times a day, and sometimes it can go up to 4 times a day when they're sick. Each of these treatments lasts anywhere from 20 to 30 minutes, and so if you can imagine a school-age child having to do a 20 to 30 minute time slot twice a day, plus take antibiotics, you think, well, that's plenty, but unfortunately it's not enough. We also encourage exercise for individuals with cystic fibrosis. I mentioned the pancreatic enzymes that children have to take with most of their meals. And as I said, oftentimes it's not 1 or 2 tablets, it can be multiple or capsules. And we actually even start this with infants where the capsules are opened and there are beads. So it can be a very trying time for a parent in order to get a child to consume these. And that's not all. They also need vitamin supplements. Because of the increased caloric intake, they have to have higher food content, multiple meals throughout the day. Imagine sending your 8-year-old to school and wondering about whether or not they're going to take their enzymes at the appropriate time and if they're going to eat all the food that it was either sent or at school that was provided. In addition, there's inhaled therapies. This can be in the form of antibiotics. There are other medications that thin secretions to make it easier so that when a child is undergoing airway clearance, they can actually bring those secretions up and cough them out. And again, those can take anywhere from 15 to 20 minutes as well, on top of the airway clearance. Modulators and correctors. Back in 2012, the first modulator and correctors were developed. These medications, they are oral, can be upwards of $300,000 a year. And that doesn't include all of the costs associated with antibiotics, the machines for airway clearance, and all of the supplements that are required. So very, very expensive. The fortunate thing is that the modulators and correctors have been able to keep children out of the hospital, which is very grateful for many parents who for years have seen their child's lung function low, and as a result of being on these medications are starting to see some upticks in their overall numbers. So it's very, very exciting. Sometimes feeding can be difficult for children, as I mentioned, and if the caloric intake is needed and they're not getting it and they are continuing to lose weight, then we need to have that discussion about the feeding tube. And oftentimes it's recommended that early, sometime in the diagnosis phase, that it's mentioned that the child may need that so that the parent doesn't feel like they're a failure because they're struggling to get those caloric needs met. Tune-ups is another word that we use when a child presents to the clinic that is having a decline in lung function with a decline in weight and increased sputum production. Oftentimes, if that occurs together, then the provider may consider that they need to be brought into the hospital so that they can have more intensive airway clearance, as well as antibiotics that are given through the IV, and really an assessment of what's going on with the child. Those tune-ups can typically last about 2 weeks, so you can imagine all of the time off that's required for a parent just to bring their child for clinic visits, which is typically at least 4 times a year, if not higher in the younger kids, and then you tack on the fact that they may need to go to the hospital. Transplant is another viable option for children that continue to decline. Fortunately, with the advent of the modulators and the correctors, we are not doing as many transplants as we used to do for that. The important thing to consider is that this is a lifelong process, and so it can be very overwhelming for a parent, and that's one of the reasons why we have a multidisciplinary team, so that we're really hitting all those aspects that are involved in taking care of a child with CF. I mentioned research. We're not going to spend a lot of time talking about that, but I did mention the modulators and correctors that were initially approved back in 2012, but that was not without extensive research. Typically, research can last anywhere from 5 to 7 years from the time of concept to the time of approval, and one of the reasons for that is because they have to find what medications are going to work. They have to be able to study it in an appropriate number of individuals. They test for safety, they test for efficacy, they look at risk versus benefits, and whether or not it would be beneficial to the public before they are ever approved. The modulators and correctors are based off of the study that we have done in the CFTR realm. When someone has cystic fibrosis, they have genetic testing that is done that determines what kind of a mutation that they have, because not all CFTR is created equal. There are some individuals that have a milder mutation, and there are others that have a more serious mutation. The most common mutation in CF is something called the delta F508. It's found in 88% of individuals that are diagnosed. In that particular class, the CFTR protein is created, but it's misfolded, and because of that, it keeps it from being able to move to the cell surface. And so when these modulators and correctors are created, they're really looking at the particular class and what they need to do in order to make that protein function. Life expectancy has certainly improved over the years. When someone is diagnosed with CF and they go to a CF center, one of the first things they are asked is whether or not the center is allowed to collect their clinical information into something called the CF registry. It collects all information, including medications, frequency of hospitalizations, lung function testing, the results of sputum analysis. And the reason they do that is because the data is collected and shared with providers across the nation to give information on incidents. It gives, so say for example, a researcher is interested in developing a study for children with CF-related diabetes. They would petition the CF Foundation to request information from the registry, and the foundation would decide whether or not they would allow that. Back in 2018, the life expectancy of someone that was born between 2014 and 2018, half of those born during that time period were predicted to live to 44 years of age. That is a tremendous difference from the 1940s when it was initially discovered. At that time, children oftentimes didn't even make it past school age. I mentioned frequent visits to the cystic fibrosis centers, typically 4 times a year. One of the things, the mainstays of those visits is making sure that parents are looking at the appropriate resources for education, and the best resource is the Cystic Fibrosis Foundation. This is another case study. I'm not going to read through. We can talk about that at the end of the presentation. So you often will see the roses affiliated with cystic fibrosis, and one of the reasons for that is many years ago when it was first discovered, there was a mother of a child with cystic fibrosis there on the right, a little boy on the left, and he came in when his mother was trying to work on donations, and he kept hearing this phrase repeatedly all day long, and he thought what she was saying was 65 roses instead of cystic fibrosis, and so that's why that has been adapted. If you see any literature out there, that's where that came from. So thank you for participating and listening to these. We'll open this up for case discussion.